Everybody, welcome back to another of my series on this time cardiovascular physiology. Today's topic is on heart murmurs. First, we're gonna divide the heart murmurs into three categories. The systolic, diastolic, and continuous. The first murmur is a systolic crescendo-decrescendo systolic ejection murmur, and soft S2 ejection click may be present. Left ventricle more than aortic pressure during systole. Loudest at heart base, radiates to the carotids, also known as pulsus parvus et tardus can be found. Pulses are weak with a delayed peak and can lead to syncope, angina, and dyspnea on exertion. Mnemotechnic is SAD, most commonly due to age-related calcification in older patients more than 60 years old, or in younger patients with early onset calcification of bicuspid aortic valve. And this is the sound. The next sound can be mitral tricuspid regurgitation. It's an holosystolic high-pitched blowing murmur. Mitral loudest at apex radiates toward axilla. Mitral regurgitation is often due to ischemic heart disease, post-myocardial infarction, mitral valve prolapse, or left ventricle dilatation. Tricuspid is loudest at the tricuspid area, and tricuspid regurgitation commonly caused by right ventricle dilatation, rheumatic fever, and infected endocarditis can cause either mitral regurgitation or tricuspid regurgitation. The sound is like this. Next one of the systolic is mitral valve prolapse. It is a late systolic crescendo murmur with mid-diastolic click due to sudden tensing of chordae tendinae. Chorda causes crescendo with click. Most frequent valvular lesion, best heard over the apex, loudest just before S2, usually benign, can predispose to infective endocarditis, can be caused by myxomatous degeneration, primary or secondary to connective tissue disease such as Marfan or Ehlers-Danlos syndrome, rheumatic fever, or cardiac rupture. The sound is this. Next sound of the systolic is ventricular septal defect. It is an holosystolic harsh-sounding murmur, loudest at tricuspid area. Next group is the diastolic one. First, the aortic regurgitation is an high-pitched, blowing, early diastolic decrescendo murmur. Long diastolic murmur, hyperdynamic pulse, and head bobbing when severe and chronic. Wide pulse pressure can be found, often due to aortic root dilatation, bicuspid aortic valve, endocarditis, rheumatic fever, and progress to left heart failure. Next one is mitral stenosis. This is diastolic, follows an opening snap due to abrupt halt in leaflet motion in diastole. After rapid opening due to fusion at leaflet tips. Delayed rambling mid to late diastolic murmur. The decreased interval between S2 and opening snap correlate with the increased severity. Left atrium more than left ventricle pressure during diastole. Often a late and highly specific sequelae of rheumatic fever, chronic mitral stenosis can result in left auricle dilatation. Can be dysphagia. If we have left auricular dilatation, we have dysphagia, hoarseness via compression of esophagus, left recurrent laryngeal nerve, respectively. The sound is this. Just one of the murmurs is a continuous type in patent ductus arteriosus. There will be a continuous machine-like murmur, best heard at left infraclavicular area, loudest at S2, often due to congenital rubiola or prematurity. The mnemotechnique is PDA. Public displays of affection are continuously annoying. This is the sound.